In the third and final module of the Airway Resistance program, we will discuss changes in resistance with various lung disorders. Your learning objective for this module is to understand and describe how resistance changes in infants with acute lung injury versus infants with chronic lung diseases. Whether by spontaneous breathing or invasive ventilation, the equation of motion indicates that the force required to give momentum to a particle is equal to the sum total of elastic, resistive, and inertial forces. During breathing, the pleural pressure decreases and increases with inspiration and expiration respectively. The magnitude of these changes is determined by airflow, tissue resistance, and elastic forces in the lungs and chest wall. The equation of motion describes the total driving force for breathing, which allows airflow from the atmosphere to the alveoli, as the sum of elastic, resistive, and inertial forces. In most cases, the inertial forces are small and can be ignored, so the pressure applied to the respiratory system just needs to overcome the elastic and resistive properties of the lung. A portion of the total pressure created for breathing is needed to overcome the elastic properties of the respiratory system to change lung volume. Most clinicians discuss the compliance of the lung, which is the pressure needed to distend the lung. So if the pressure is low to achieve a reasonable volume, there is not much pressure or energy needed to overcome the elastic properties of the lung. Another portion of the total pressure is used to overcome the resistive characteristics of the respiratory systems to create airflow. Resistive pressure is proportional to both flow and resistance. The total pressure required for movement of gas is equal to the sum of elastic and resistive pressures. This equation shows us that driving pressure is directly proportional to volume, flow, and resistance, and is inversely proportional to compliance. When assessing patients with lung disease, it is preferable to consider whether the lungs are dominated by low compliance or by high resistance. In general, lung disorders dominated by low compliance are acute lung diseases with stiff and/or small lungs. The common diseases in neonatology dominated by low compliance are respiratory distress syndrome or pulmonary hypoplasia. Ironically, in patients with these acute lung diseases, airway resistance is high in the most diseased portions of the lung. In patients whose mechanics are dominated by low compliance, the time constant is short. Time constants measure how quickly the lung can inflate and deflate. A time constant is directly proportional to both compliance and resistance. In situations of decreased compliance, like RDS and pulmonary hypoplasia, a decrease in lung compliance will decrease the time constant. Since the time constant is short, lungs will inflate and deflate quickly, and clinicians can utilize respiratory strategies with fast respiratory rates. In the most diseased parts of the lung, the resistance is actually high, so in fact, this area of the lung fills and empties more slowly, or is called the slow space, than the majority of the lung, which is referred to as the fast space. In general, patients with surfactant deficiency have low lung compliance overall with short time constants. However, the most diseased parts of the lung have collapse of the alveoli and the airways. This leads to small radiuses and high airway resistance. The most effective maneuver to affect this compartment of the lung is to introduce generous positive end expiratory pressure, or PEEP, whether it is with invasive or non-invasive respiratory support. The balancing measure for this maneuver is that the part of the lung with sufficient surfactant may become overdistended. This overdistension in the surfactant-sufficient areas explains why patients with surfactant deficiency can develop air leak syndromes and why alveolar rupture occurs in the portion of the lung working well. In a study of premature infants with an N of 20, mean airway pressures were changed by either increasing the PEEP, increasing the PIP, or increasing the I to E ratio. All maneuvers that increased the mean airway pressure increased the arterial PO2, but increasing the PEEP was the most efficient and in other studies was the safest way to improve lung function. Let's move on to diseases with high airway resistance instead of low compliance. In general, lung disorders dominated by high resistance are found in patients whose airways have been damaged because of the disease process itself, and more commonly by the supportive care applied to save the patient's life. The common disease in neonatology dominated by high resistance is bronchopulmonary dysplasia. In patients whose mechanics are dominated by high airway resistance, the time constant is a very large number for the lung as a whole, meaning that it takes a long time to fully inflate and exhale. Due to this long time constant, in patients with BPD or early airway injury, it takes much longer for alveoli to fill and empty completely, so that support strategies utilizing slower rates and higher tidal volumes are necessary to avoid air trapping until the lung heals. In general, we can use our knowledge of resistance, compliance, and time constants to craft sensible strategies for respiratory management of patients in the NICU. Acute lung disease is usually dominated by low lung compliance. Patients usually have small, stiff lungs with short time constants. In RDS, the most severely affected areas of the lung, the surfactant-deficient alveoli, actually have high resistance, but this compartment is relatively small. Management of lung disease with low compliance is best addressed with increased PEEP and faster rates, if needed, given the short time constant, whether on invasive or non-invasive respiratory support. Chronic lung disease is usually dominated by high airway resistance. The most familiar lung pathology in this category is BPD. The sickest part of the lung has high airway resistance and can represent the majority of the lung in many cases. Because of the high airway resistance, it takes the lung a longer time to fill and empty. Thus, the time constant is long, and patients with chronic lung disease benefit from management strategies that provide a larger tidal volume and a slower rate. This concludes Module 3 and the Airway Resistance Program. Thank you for your attention.
We would like to acknowledge the American Academy of Pediatrics, the Organization of Neonatology Training Program Directors, Neo Reviews, and Abbott Nutrition for their support of this educational program. This concludes this module.